Request Dr. Jatinder Singh Bhalla to start off our session with his talk on rise in intraocular pressure during and after cataract surgery.
Good morning, everyone. At the outset, I'm thankful to Dr. Namrata Sharma for giving me this opportunity. I'm going to talk on rise in intraocular pressure during and after cataract surgery. IOP, there is a decreasing effect of on IOP of cataract surgery, which lasts for about 3 to 6 months, and this is to the tune of 1.1 to 2.5 millimeter mercury for at least 6 months post-operatively. But IOP may also increase in the early or late post-operative periods, and this is particularly significant after congenital cataract surgery. And there is increase in IOP during the first 24-hour cataract surgery, which is a major post-op complication. This may initiate at 2 hours with a peak at 6 hours and last for 24 hours. Why it is important is because it may not only cause pain, corneal edema, but it may also cause complications like NAION, retinal vascular damage, and patient may complain of decreased visual acuity. And the exact mechanism why it rises is probably multifactorial. Why IOP rises during cataract surgery? For a typical eye with an anterior chamber depth of 3 mm, the volume of anterior chamber is just about 0.2 ml, and the posterior chamber volume is even lesser, that is 0.04 ml. So this makes combined volume of 0.24 ml. That is, just imagine, it is equivalent to just 6 to 8 drops in which we have to remove the cataract and insert the IOL without causing damage to the ocular structures. And what is the relation between the bottle height and the intraocular pressure inside the eye? If we calculate 15 centimeter bottle height above patient eye level is equal to 11 millimeter of mercury of intraocular pressure. So if we have bottle height of 100 centimeter, this induces pressure, IOP pressure of 74 millimeter, and if you have bottle height of 90, it causes IOP of 66 millimeter of the mercury. So when surgery starts and you have infusion level at 100 centimeter, it causes 74 millimeter of the mercury, and this is very high pressure. So when you go in foot position 2, what happens is then there is some aspiration also, and this will cause IOP to decrease. But if you go in just foot position 1, the IOP will be very high, which may be hazardous in patients with moderate to severe glaucoma. And then another important entity is mean arterial pressure and mean ocular perfusion pressure. Mean arterial pressure is diastolic blood pressure plus 1/3 of the difference between systolic and diastolic. And mean ocular perfusion pressure is 2/3 of this mean arterial pressure minus intraocular pressure. So if you have systolic of 120 and diastolic of 70, then the mean arterial pressure is 87 and mean ocular perfusion will be 38 millimeter of mercury. And so if you go with bottle height of 100 millimeter of mercury, 100 centimeter, which is 74 millimeter of mercury, what will be the mean ocular perfusion pressure? It will be 2/3 of 87 minus 74, that is minus 16. That means during this bottle height of 100 centimeter, your ocular flow will completely stop during this part of the surgery, and longer you stay at this bottle height, particularly in patients with compromised blood flow in moderate to severe glaucoma, it is going to be really hazardous, and you may have done excellent cataract surgery, excellent phaco surgery, and next day you find that the patient's vision is gone because of this high intraocular pressure which you have maintained for a longer period of time. Another important condition is acute intraoperative rock-hard eye syndrome. This may particularly occur in hyperopic eyes during uneventful phacoemulsification, and what patient presents is with a shallow AC with absence of suprachoroidal effusion, and this may occur hours after the initial surgery, and this is due to inappropriate movement of the BSS via the zonular fibers behind the lens. So so what we can do with this increased bottle height, we have another mechanisms like Alcon Centurion has active infusion fluidics, which really takes into account, because here it is not gravity dependent. So you can do the surgery at a target pressure of 20, 30 or 40 millimeter of mercury without compromising on the phaco parameters like flow rate, vacuum, etc. Active fluidics technology makes you operate at a target intraocular pressure and also maintains surgeon selected target intraocular pressure. And so this active fluidic technology is very important. It not only provides excellent chamber stability but more natural IOP targeting. IOP control is there in other phaco machines also. Johnson & Johnson has come with on-demand fluidics. Stellaris, Bausch & Lomb has adaptive fluidics, and this helps to stabilize intraocular pressure. So an important parameter which we used to neglect is now being taken care of in the advanced phaco machines. Then there are the intraocular pressure may rise post-cataract surgery. This can be classified into open angle and closed angle glaucoma. Hyphema, if is significant, may cause both open angle and secondary glaucoma due to trabecular meshwork obstruction by RBCs, or PAS may form. So what we have to do is, if it is very mild, then we just give anti-glaucoma medications along with the topical steroid drops. But if it is high, particularly in patients, and you find that the intraocular pressure is particularly high, about 35 to 40 millimeter mercury, maintained for a longer duration, particularly in patients with mild to moderate glaucoma, then this is hazardous and you may have to do paracentesis or AC wash. Uveitic glaucoma can occur particularly if you patients operate cataract surgery in patients with uveitis. It can cause open angle glaucoma due to trabeculitis or secondary open angle glaucoma, particularly in you do cataract surgery in patients with heterochromic cyclitis. And angle closure can occur from if you are doing in patients with rubeosis iridis. So UGH syndrome is no longer a significant entity, particularly we have shifted from AC IOLs, but it can occur if you are implanting hydrophobic IOLs in the ciliary sulcus, so UGH syndrome can still occur. This is another important entity. If you have left behind some epinucleus, nuclear fragments in the anterior chamber, then you can have rise in intraocular pressure. Steroid-induced glaucoma is something which we neglect, cataract surgeons neglect. If you are giving steroid for long duration of time, then you find that everything is okay, but the intraocular pressure is high. This may be due to entity of steroid-induced glaucoma. Viscosurgical devices have to be completely washed out from the anterior chamber, particularly the dispersive is difficult to remove, although cohesive comes out instantly. So what we can do is a very good technique advocated by Uday Devgan. This is called angle sweep. Just perform an angle sweep with injection of BSS via 27 gauge blunt cannula, and this can release the viscoelastic from the angle of the anterior chamber, and then you can easily aspirate it out. I won't go into details of capsular block syndrome. You find that suddenly the intraocular pressure postoperatively is high, and there is unexpected myopic over refraction because this is fluid accumulation behind the lens, and the IOL comes anteriorly and the capsular excess margins blocks it. So treatment of glaucoma after cataract surgery can be done with topical and systemic aqueous suppressants along with steroid drops, and in rare cases you may require, if there is pupillary block, laser iridectomy for pupillary block, and other surgical measures like AC wash, etc. may be required. So elevation in IOP may occur early or late in the post-op course and can be associated with either open or closed angle, and there it is multifactorial. Thank you everyone for your kind and patient hearing, and I take this opportunity to invite all of you to the annual DOS conference, which is going to be held from 10 to 11th February in New Delhi. Thank you.